Welcome, everyone. Welcome, everyone. I'm going to get started. For those who I haven't met yet today, my name is Michelle Macheski, and I'm a conference co-chair and certified physician assistant in the high-risk breast clinic. It is my pleasure to introduce to you Dr. Jan Carney, who will speak about rural health disparities in Vermont and what we can do about these findings. Dr. Carney is an associate dean for public health and health policy and professor of medicine at the Larner College of Medicine at the University of Vermont. She's active in teaching, research, practice, and advocacy. She serves as core director of the Community Engagement and Outreach Core for the Northern New England Clinical and Translational Research Center, focusing on engaging communities and advancing research, especially in rural areas. She directs Larner College of Medicine's Master of Public Health and other graduate programs. Before coming to UVM, Dr. Carney served as Vermont's commissioner for 3 gubernatorial administrations. Thank you and welcome, Dr. Carney.
Thank you very much. I'm delighted to be here. Ordinarily, when you're going to ask speakers questions at the end, I have questions for you, and I'm going to ask for your opinion and your feedback about some of the things that we could do right here in Vermont. So here's the learning objectives. We're going to see how big a problem this is. We're going to look at some of the causes. We're going to look at the data, some key literature, and I have a lot of resources. A lot of what I'm going to talk about is publicly available, and I'll give you, and you'll have the available slides with all those links for those so that you can look at this later if you want to know more. Then we're going to talk about some potential strategies to achieve cancer health equity, what works, and a little bit about our research and the Rural Health Communication Network and community engagement. And then think about, and that's what I want to ask you all, what can we do so that things are better? My only disclosures are that I've written several textbooks in public health and received royalties, but I will not be discussing any of these today. This is a wonderful picture about health equity. And as I think about everything we're trying to accomplish, I think about this first and foremost. This is from the CDC and the NCI. And we think about how hard it is so that everybody has the same opportunity for health. I found this one, and this is in this county health rankings and roadmaps. I'm going to talk a little bit about that. And I like this one even better because look at equality. In this picture, everyone has a bicycle. But in equity, everyone can ride that bicycle. And this sort of exemplifies how incredibly hard it is to give everyone the same opportunity for health. All right, this is a little bit of data. Don't be intimidated by this. And the only reason I put this up is in public health issues are common, they're serious, and they're in part preventable. So the corollary to this is if we can even make a very small difference in a public health issue that translates to better health for many, many people and has a huge impact. So this is from the Vermont Cancer Registry, Department of Health, and the top one is incidence rates 2015 to 2019. So this is pre-pandemic. And I just put this to show you like what are the most common new cancers in Vermont overall, and what cancers are the leading causes of cancer deaths in Vermont, just to keep that perspective. And then when we talk about what can we do, I think it's really important to also focus on how we leverage improvements in things that are impacting a lot of people here. So we have, in terms of all cancers, new cancers, lung and bronchus is leading for males and females, prostate for males, and breast for females, and then cancer death rates for that same time period It's for lung and bronchus for everyone, and lung and bronchus for males, and lung and bronchus for females. Here in Vermont, we have the Vermont 2025 Vermont Cancer Plan. And I saw there's a table out there and with handouts. This is probably one of the single most important things that we can do. We have a plan, we use the data, we use evidence-based strategies, we work collectively to try and make progress. This is from the Vermont Department of Health, and it's also from the Vermont Statewide Cancer Coalition, Vermonters Taking Action Against Cancer. We have a coalition. We have many, many people who want to make things better. That's absolutely foundational for us. I'm not going to talk about all these different categories. I'm going to focus on today health equity, ensuring that all Vermonters have a fair and just opportunity to be healthy. And you can see the different focus areas of this plan. I'm going to suggest today that we add rural to that. And I'm going to show you the data in just a couple of minutes. Well, I'll be talking about cancer prevention and some of the focus areas there. Early detection and some of the screening for the most common forms of cancer. And some of the barriers that I'm talking about are also relate to people having trouble getting access to cancer treatment. My message to you today is that place matters. This is the time of year where if we can drive around at all outside the state, we see beautiful foliage, we see winding roads, we see incredible scenery that makes us so grateful that we live here. That same beautiful winding scenery road can also make it challenging. And this is every road Craftsbury mud season edition. And you all know, particularly if you live outside of Chittenden County, many people outside of Chittenden County, that there are roads that aren't paved. Winter is winter, and it's sometimes very challenging. And those create very just practical barriers to people because of where we live. Let's look about from a national perspective and for rural versus urban areas. And this is from the National Cancer Institute, the Rural Cancer Control Division of Cancer Control and Population Sciences. And this is across the United States. In rural areas, there are higher death rates for all cancer sites combined. There are higher incidence and death rates for smoking-related cancers in rural areas. There are higher incidences of cancers prevented by screening, some cancers, particularly cervical and colorectal. And there are differences in rural health behaviors associated with cancer. As an example, in rural areas, there are higher rates of tobacco use on the average, alcohol use, obesity, less physical activity, fewer sun protective measures, and lower HPV vaccination rates. In addition to this, as you know, there's many social factors that impact our health. On average, in rural areas, we see higher poverty rates and lower educational attainment. There's less access to health services. And some of those rural barriers for accessing health services, sometimes they're financial, sometimes they're transportation. I keep that visual mud season picture in my head. And then sometimes there just aren't as many preventive and screening services available and convenient to people. One of the areas where we do need research is in looking at, and I'll show you some of these different definitions of rural and how we best use them in cancer prevention and control research. This is from the National Cancer Institute, their GIS portal for cancer research, and this is publicly accessible. And this just shows you rural, urban disparities in cancer incidence, all races, both sexes from 2013 and 2017. And I just put this up here to show you how many differences there are depending on where we live. Let me show you across the United States. This is from the same NCI data set. Rural urban disparities in incidence, new cancer cases for common cancers. And the green is rural and the yellow is urban. So for example, in the area of lung and bronchus, you see higher incidence rates in tobacco-related cancers in rural settings. Likewise with colorectal cancer. Let's look at the same rural-urban comparisons for cancer deaths. Here are the pictures of just a little bit different, but for lung and bronchus, we see higher death rates in rural areas. Likewise, we see higher death rates for colon rectal cancer. This shows that there are a variety of different definitions of rural. So one of the challenges is what I just said in terms of the need for research of which definition can help us more as we're doing different research. It also makes it more complicated. So let me just explain sort of how I'm thinking about it in terms of the actions that we can take in our communities. So the upper left has to do with the red area, the more urban places, and this is based on census data. The lower left has green, which is the more urban areas, and that's another different way to do this based on census data. The upper right is based on the Office of Management and Budget and looks at metro counties. So for this, you see 3 counties, Chittenden County and North and Northwest, that fall into that category. The bottom one is based on the Rural Economic Research Service Rural Urban Commuting Areas. That was a mouthful. It's RUCA codes. And what this is that it takes into account the census and also commuting. And so if you look at this, it's Chittenden County and parts of the surrounding county. I personally like this one. I think it's very intuitive and practical, and we're using this in some of our research. So let me just show you the definition. This is not a statistics or epidemiology lecture, but I do want you to see this. Okay, these are the rural urban commuting area codes, and they look at the census and population density, urbanization, and commuting. And they go from a scale of 1 to 10, and there's the link for those. Another great source of information is from the National Cancer Institute and the CDC, and these are state cancer profiles. And if you look at this, and you can look at any state, and you can find out incidence, deaths, demographics, and screening and risk factors for a long list of cancers. So let's look at incidence rates, new cancers for Vermont by county, for all cancer sites, all races, both sexes, all ages from 2014 to 2018. And for some of this data, it's not available publicly till at least a couple of years after it's collected. It just takes time to assemble all that. So most of the data I'm going to show you is pre-pandemic. So if we look at this, and the yellow and the lighter green are the lower rates, and then the blue, and you can see that my point is just that there are differences based on where you live. And this is a similar map that shows deaths instead of new cancer cases. And again, this is for everything. And you can see the darker blue and the darker shades of blue on average tend to be in our more rural settings. This is from the Rural Health Information Hub, and the data is from the National Center for Health Statistics. It ends in 2015. And the top line, and this is the deaths per 100,000 people for cancer for metro and non-metro areas in Vermont. And you can see the bottom line is for metropolitan area, and the top line is for non-metropolitan area. So again, differences in where you live, whether it's rural or not. And this starts in 2006 and goes to 2015. So for me, this is something I put in a category of a really challenging and enduring problem, which is why I think we need some new approaches and some creativity. And that's where you're going to come in. to help us figure out how to do better. This is another way, similar data. This shows for Metro on the top, and this is for Vermont and the non-Metro, and this shows expected and potentially excess deaths. And again, we expect to see not only more deaths, but an excess number of deaths in our rural communities. Some of those social factors, I'm just going to show you a couple of them. And this is median household income. This is from 2020. And the lighter colors is a higher income. So in this case, if you look at Chittenden County and some of the surrounding counties, that's where we have the highest income. And that financial or those differences can be a financial barrier, whether we're talking about prevention or access to treatment. Another challenge that we have in our rural state, and I'm showing you primary care physicians per 10,000, and this is from 2019, and this is from the same information source, the Rural Health Information Hub. It would also, if I show you all physicians or include nurse practitioners, you get a similar pattern, which is the highest number of primary care physicians per 10,000 people, again, is in our more populated settings here. So put this all together. Think about all these things I'm showing you in terms of some of those differences between whether you live in Chittenden County or just outside Chittenden County or out in the rest of our state can cause some tremendous challenges for patients. Just a few more data slides. This is, again, publicly available information from our own Vermont Department of Health. They have cancer data pages and they update them regularly. Obesity is associated with 13 different types of cancer. And in terms of primary prevention, proper nutrition, physical activity, one of the most important things that we can do. And you can see that when I look at these maps, these are comparison to the overall state rate. So I ask myself, are there counties where the rate is higher than the overall state? And also the second question I ask is the overall state rate just way too high? So we need to do something across the board, plus maybe focus on certain rural counties. So in this, 27% overall. And actually that scale on the right is a typo. If you look at Orleans and Orange and Rutland County, you'll see those obesity rates as a percentage of the population. Rutland is 38%. Chittenden County is lower. But again, these are opportunities for prevention. Tobacco. And most of the map is blue, and overall 16% of adults are smoking. But adults in Orleans County are smoking at a higher rate and Chittenden County at a lower rate. So we might ask, what's going on in Chittenden County that might help the rest of our state? And also Vermont adults smoke at a higher rate than the US population. So again, opportunities for prevention, as we know there are a long list of tobacco-related cancers. This is HPV vaccination rates, cancer prevention beginning in adolescence. And here we see that the rate overall is 59%. So we're not even at 60% yet of things we can be investing in prevention for the future. And then if you look at, and the highest rate, and you can see the map, and the orange is lower than that state rate, which is pretty low. And if you look at the highest is in Chittenden County, it's still under 70%. So this was an area in terms of a priority for the future. Colorectal cancer screening, again, 72% overall. Windham County is statistically lower. We're about the same as the US, and we know across the US that we do have to continue to find ways to get more people screened as recommended for colorectal cancer. Lung cancer screening, So the U.S. Preventive Service Task Force recommends annual lung cancer screening for adults 55 to 80 who have a smoking history of 30-pack years or more, or who currently smoke or have quit within the last 15 years. So about 4% overall of people are eligible for that screening. And you can see in Essex County, more people are eligible, and also in Rutland County. But this is the statistic that impressed me, that only 1 in 5 Vermonters who are eligible for lung cancer screening meet the screening recommendations. Think about that first very busy chart that I showed you with the cancer that kills the most people here in Vermont. Pandemic impacts. So that was pre-pandemic. So there's a growing literature from the pandemic time, and there were documented delays in screening, treatment, clinical trials for a while, risk related to the pandemic, as we know, health risks, and competing healthcare needs out of necessity, right? There were some delays in diagnosis, and then we know that COVID did not impact people uniformly and was unequal in a variety of communities, and that was particularly a concern for health equity. And also there were survivorship impacts that were unequal. Just a couple studies to show you. There's lots of studies on the left, and this is from Nature, and it's from a study that was in JAMA Open in 2021. And this was breast cancer screening before and during COVID in one San Francisco hospital. And on the left scale is the cumulative number of mammograms. And the blue line, you can see, and look to the far right for 2019. And if you look at the orange line below, that's for 2020. So that would be during the pandemic time. It's about 2,000 less just for that one hospital. On the right, cancer diagnoses before and during COVID in the US. And you can look at the number of diagnosed patients. So if you look all the way to the left, it's pre-pandemic. And I'm just going to point you to the top 2 lines, prostate and breast. You can look at that. And go to the right, November 2020 to March 2021. And you can see that there were fewer diagnoses of prostate and breast cancer related to the pandemic. Okay. I'm not intending to paint too grim a picture, because it doesn't have to be this way. There are things we can do. So let me shift to a brief discussion about what we can do, what works, and what works in terms of the evidence to support us doing that. Many people, there's 3 main sources that I use. And the first, and many people are familiar with the U.S. Preventive Services Task Force that makes evidence-based recommendations for patients. And they look and they review the literature, they grade it for an A or B is recommended. And I'm just showing you, they have these recommendations and they update them on a regular basis. I'm just showing you for colon cancer, and you can see screening recommended for the population. Adults 50 to 75 gets an A, and 45 to 49 gets a B. Those are all recommended. As an example, not as many people are familiar with something that's an analog to this called the Community Preventive Services Task Force and the Community Guide, which is for populations. It's real world in communities. It includes both evidence and economic benefit for doing this. And it's a population equivalent for what the U.S. Preventive Services Task Force does for individual patients and populations of patients. This is for entire communities. And this is another complementary source of evidence-based information that can help us as we're trying to reduce risk factors, improve access to clinical preventive services, and also treatment. So you can see that they have an entire section on cancer. Another more recent source that I like, this started as the Robert Wood Johnson Foundation, County Health Rankings and Roadmaps. And it's a great source. You can look at any county in the United States and see all about their health, their social service indicators, social determinants of health. healthcare, public health metrics. And they've added a new section called What Works for Health, where they've added all the evidence for health behaviors, diet and exercise, tobacco use, clinical care, access to care, social and economic factors, and our physical environment. This is a very easy to use source. All right, let's look at some examples, a few examples of evidence-based strategies. Access to care. Community health workers. Community health workers often usually have training, but they're not trained necessarily as doctors or nurses, and they serve as a bridge between people in individual communities and healthcare settings. Health insurance enrollment, outreach, and support. Health literacy. I particularly like this. I think we can go a long way and do a lot if we have a better informed public, which is on us to provide that education that people can be partners in their own health. Rural training and medical education, rural transportation. And on tobacco cessation on the right, you can see those evidence-based interventions. And for cancer screening, breast, cervical, colorectal, interventions to engage community health workers to increase cancer screening. What does that mean? That means both individual and community-based education, multi-component interventions. That means both targeting things inside the healthcare system and out in the community to try and improve people's knowledge and their access to preventive services and to care. I want to pivot for just a minute to some of the research that's going on here in Vermont. And this is the Northern New England Clinical Translational Research Network. It's in year 6 now. It's a very large NIH grant, and with Maine and Vermont and New Hampshire. And it's collaborative research. It's translational research. It's taking the science and putting it into practice across Northern New England. And that, of course, is something that can potentially help us in rural areas. We want to increase the amount of research in these things of how to do better that I'm showing you where those differences are. I direct the Community Engagement Outreach Corps, and this links to healthcare, academic centers, community organizations, many people across our tri-state area. I'm convinced that this is one of the things that can help us. We have rural research navigators serve as community ambassadors to help conduct, promote, and advance community-based engaged research in Northern New England. Here's the spectrum. What does community engagement mean? This is from the CDC, and I like this because it sort of makes us be more deliberate in thinking about how we actually engage individual people and also organizations to focus on health. So everything from outreach, and that's kind of this one-way communication, and consultation, involvement, collaboration, and shared leadership. So it's a spectrum. And the farther we move along that spectrum, the more we can engage, help people become more educated about their own health and gain the public support to do what we need to do to keep ourselves as healthy as possible. Just a minute or two on some of the research that we're doing that's related to that. I call it Beyond Broadband Internet Access, and we've been working to develop a rural health communications network to promote health in rural communities, and that is part of the overall strategy of community engagement. My hypothesis was that health information and communication preferences differ in rural and urban settings. So we've been collecting some data around that. And I'm just going to show you one survey that we did in partnership with the United Ways across Vermont. It was about 6 months into the pandemic. And the United Ways, there were so many health and social needs then. We all know that food security was a huge issue. Mental health, offices were closed. It was really, really hard. So what they were trying to figure out was, how can they best use their resources across the state to help the most people? So we work with them, and actually an entire class of medical students, and help with this statewide survey And we looked at all those different categories. The piece I want to just share with you today is health information and communication, what we learned about that. And we looked specifically at some comparisons in rural areas in Vermont. So we had over 1,000 responses, and generally, not surprisingly, and that's really important to me because of that, what works is improving health literacy, is more health information is needed in Vermont communities. And we heard that across the board. And then we learned over some very important rural versus non-rural differences in how people wanted to get health information. And people in urban, so Chittenden County is an example, people wanted to get health information from the internet, front porch forum, and TV. Whereas people in our rural communities wanted information from their town newspapers and word of mouth and posters and Facebook. So how does that help us? I think we're learning a lot in this regard and this two-way communication, because when we think about it, if you think about how we often get health information, it feels like it just goes one way, right? Somebody send out a message and there it is. And you don't know, did people get it? Did they understand it? Did they act on it, right? So I'm thinking about this rural communication more in terms of a community conversation. It has to be two-way. We have to know if we're providing health information that can be life-saving to people in a way that they want to receive it and they'll act on it, right? I think this is essential for rural settings, particularly for rural settings. So, and if we're able to create systems, think about this more deliberately, we can help with access to healthcare, social services, improve health literacy, conduct more research, all the things that we know that we need to do to make the health of Vermont better, right? And we learned that there are differences. We already know there are differences in how rural and urban areas prefer health information. I think this knowledge can help us develop and test specific strategies to reach people everywhere in our state. So, all right. And I know there's people online. So I'm gonna ask, here's where you come in, and we still have some time left. We need your help. I've given you a lot of data. All right. Hopefully I made the case that things are different if you live in a rural place or not, right? And there's a lot of information on what works. And we're learning that it's really, really important. And that is part of how we like to do things here in Vermont, is we engage people, right? And becoming partners in their own health, kind of like this conference today. And so what ideas do you have to reduce or eliminate rural health cancer disparities? If you are watching through Zoom, if you could just think for a few minutes. I'm going to give you like 5 minutes. If you can think for a minute and type any of those suggestions in the chat in Zoom. If you're here in the room, Elizabeth Woods is one of our rural research navigators. I'm going to ask you to, there's paper and pens at the table, write them down and raise your hand and give it to Elizabeth. All right. And then after that 5 minutes, what I would love to hear, I'm happy to answer questions, but I'd like to hear even more is your suggestions for things that we could do. So take 5. Don't go away. Take 5. Any and all ideas are welcome. If you have an idea you want to write down, you've written it down, just raise your hand and we'll come get that. And then we'll spend a few minutes talking about some of these. Okay. Yeah, I'll give it to you. Yeah. Yeah. Okay. Thanks. Somebody gonna, oh, yeah. Yeah, that's okay. Well, I'm gonna try and get that. Thank you. All right, and again, if you're on remote on Zoom, love to hear all of your ideas. Please type them in the chat. Okay, great. All right. You can still keep writing. Just raise your hand if you have something. We'd love to hear it. Would anyone like to discuss any of their ideas?
So Jan, that was a really nice talk. Thank you. Thank you very much. I'm more focused on the mortality differences between rural and urban. The incidence differences we can try to address with better screening and education. Yeah. But the mortality, I think, is more complicated because it relates to access to care, delays in diagnosis, diagnosing cancer at a later stage. Those are difficult to address because we have significant workforce shortages in oncology as well. So I wanted to ask what your thoughts are about transforming the workforce here in the state of Vermont to better utilize advanced practice practitioners, nurse practitioners, and physician's assistants who may have oversight from physicians at a more urban center like here in Chittenden County. The big barrier to that at the moment is that there is no insurance reimbursement that's adequate to sustain that kind of workforce under our current fee-for-service model. So I wondered if you had any thoughts on that.
That's a really tough one. One we've been struggling with for a long time. I think you're exactly right on point. And the question is, I showed the data for physicians. We know that we've been, in terms of rural healthcare coverage, it's been fragile for years. So how do we incorporate, adequately reimburse those teams? Because really healthcare is a team sport right now. I think we have to look at population-based models and the assumptions for the HCO when we're looking at those, as people are looking at changes in fee-for-service or new models of care. I think we have to talk with our congressional delegation, and I think we need to continue to shine a light on it because, as you point out, Dr. Holcomb, the mortality is, we're not going to impact that unless we have an adequate workforce to provide the care that is needed.
We have a ton of Zoom suggestions, so I can only, I assume, read a few, but we're going to be saving the chat, so I can send that along to you after.
Go ahead.
Awesome. So Laura says a hub and spoke model for cancer care centers in rural communities is her suggestion. Roseanne Town recommends education in conjunction with public school system. reaching out to students as well as parents. And they're still coming in. I don't think I'm going to be able to get to all of them. Leslie Murray says, improve transportation opportunities, improve education and support opportunities. Mentorship may help bridge between healthcare providers and accessing and following through on screenings, treatment, etc. Should I keep going? Or okay. Ginger says, support for local doctors and clinics in rural communities. Let's see, public library settings, information meetings. Mobile health units to rural areas, offering informational booth at town hall meeting day, which is the big one. Easier parking or more accessible locations for those needing the Cancer Center services. Traveling specialty screening clinics. Support for transportation to medical facilities. And let's see. Somebody wrote in all caps, free health screening programs. Traveling lab services, other states have them for homebound populations, apparently. Home visit team. Please let me know if I should. If there are other questions, I can stop. Kim says, please consider outreach to community organizations, clubs, gyms, etc., that might include populations who are not connected with schools, libraries, and medical facilities.
Awesome.
Yeah, great.
That's wonderful. Thank you. Anyone? Oh, here we go. Go ahead.
Hi, one of the things I wrote down was taking the information to where a lot of people that live in rural communities frequent, and things that come to mind for me are places like Farm Way, Sticks and Stuff, Lenny's, Shoes and Apparel, you know, places where people who live rural lifestyles go to get their things they need on a daily basis. And having, you know, either through, you know, finding a grant or something like that, a cycle where either an education team or a booth with information is set up to bring prevention information to those communities. Because, you know, a lot of people don't know how to connect something they're experiencing. Perhaps maybe they're having some kind of symptoms of a problem where, you know, educational material can say, well, if you happen to have this, this, or this, you might want to go get checked out. But also things like, you know, sunscreen. I think of some of these clothing outlets and having, you know, information about the benefit of UV protective clothing, wearing hats and things. Of course, you're talking to a melanoma patient, so that's the top of mind for me, but other types of things, colorectal screening, and the importance of that as well. So
Thank you. Probably time for one more.
On the prevention side of things, when I think about physical activity, I think one of the challenges we have in rural communities is that everyone drives to do literally everything. There's no sidewalks for the most part. And in towns where we have tried to put in sidewalks or pathways for people to walk more easily, it's often met with resistance unless it's sort of a trail, and trails are more difficult for some people. We also have struggled with getting public schools to open their gyms because of liability issues. And so, you know, I think there's something around the built environment too that we need to sort of think about and address in rural communities. And it's particularly challenging, obviously, in the winter.
Yeah. Thank you. All right. I just want to leave you with, I appreciate this very much. And I guess all these suggestions, keep thinking about them. I think we really have to shine a light on this. And I think that advocacy to make things better when we use what works can be something very powerful indeed, and something that we know how to do here in Vermont. Place matters. in rural health, equity, and cancer. We have data and research to guide us. Yes, we need more research. Some of the models of care, potentially care, creative ways to get people into screening. Absolutely. Community engagement, I think, will really help us if we work harder, more deliberately at this. And then understanding health communication is essential. I think we can do much with what we already know. And if we follow the science and the best practice and that we're creative, I think we're good at that also. And so just remember, and something I always remember every day, that even a small improvement in a public health issue translates to better health for many, many people. So I'm going to end there and thank you very much.